let's come back to that. I understand the third reason you just gave. I don't understand an insurer having a concern with side effects. That's the physician's job.
No, it's the insurers too. We have to be as responsible for those on a population basis. If the drug's not tolerated, it's not going to work because patients aren't going to take it. If it doesn't work, it has both a clinical and economic burden.
Yeah, but that's covered in the FDA approval process. And that's pretty rigorous. You know, safety is a part of every phase, and they review that quite carefully. So I just don't understand that argument.
Yeah, I would actually argue about the safety issue very much so. We've had a lot of drugs that have been pulled off the market over the past 10 years, in fact more, because when you try it in 10,000 people or 1 million people, you still don't see the side effects actually that you do once it hits the real world. So, and I could go through with you and talk about all the ones that we've seen. But the second thing I do have to also say is that because we do cover the cost of the bradycardia or the lymphopenia or the side effects, the increase in transaminase levels and the increase in LFTs, that is being paid for by the managed care, by the insurance company. So you can say, you know, you worry about the side effects. We very much worry about the side effects also. Not only what is it doing to the patient, not only, you know, flushing, GI, nausea. Some of the newer ones, I'm interested. Even what we've talked about before is that we have to wait and see. I don't think the data's there yet.
So
but
this
I think
is very interesting. So it's almost like you're saying that new agents coming on board, there's almost a bias to say, yes, you've been FDA approved, you've been given a stamp of approval, but we already have tried and true therapies. Let's hold back. Let's wait and see. Let's get more data. Is that sort of the attitude?
You know what? We have 20 years of experience with the interferons. We have 6 months or 3 months of data with the orals. Yes, the idea is that they may end up being safer. We just don't know yet. And I sort of liken this to other categories of medications, so antidepressants. And they had the old antidepressants that did cause certain side effects, and there were movement disorders and extrapyramidal side effects, et cetera. And then we had all the new antidepressants, which now are old, but it was a different set of side effects. And we're going to have the old side effects of the depression, the flu-like syndrome.
It's very interesting. I don't agree with you, but I think it comes back to these drugs are too doggone expensive. They shouldn't cost as much as they do. I'm sorry. And if they didn't cost so much, it wouldn't be an issue in being able to use new drugs that I think are very good.
I don't buy the side effect story for a minute. Okay, we all know that there are agents that come out, and until you get out into the marketplace, you don't see the risk. We've had agents pulled off the markets for years now because of things that came out after the phase 3 studies. I understand that. I just don't believe the insurer cares about that. And I don't think you care about the cost of the side effects because that's already in there. You understand that when the drug's approved. I think this is all economics. I don't believe you're making choices because you're worried about side effects.
You haven't sat in our desk. And we are first clinicians. We are first wanting to do the right thing. And we have to have the dual role of balancing the economics and the clinical outcomes. So I'll politely disagree with you. We do care about patients. We do care about clinical outcomes. It's the first thing out of people's mouths in a P&T discussion. The economics come much later.
In fact,
and again, until you walk that mile in our shoes, I think that's probably not a fair characterization.
But when it comes down to responsibility for the decisions, you take none.
Yes, we do.
And you've been exempted from it.
Not true.
You've been exempted from it for federal law. And the responsibility ends up for the clinician. And so you're making decisions, and you're saying you're making decisions either on efficacy and safety for which you take no responsibility.
We have a responsibility to our members. We have a responsibility to our customers, and we have an ethical responsibility to ourselves. So on an individual patient basis, you are absolutely correct. On a population basis, if we are a health plan that has made a very bad decision, we will be responsible for that because ultimately our clients will vote with their membership and their renewals. So we have the responsibility. It's a different level. Again, it's a population level which is very difficult to understand unless you've managed populations.